Good morning, Dr. Phil here. Today we will be discussing on systemic oxygenation. Introduction. An understanding of the principles of oxygen delivery will enable the clinician to optimize oxygen flux to patients, which is particularly important in situations such as in critically ill patients, patients undergoing major surgery, and in goal-directed therapy. Oxygen is essential for energy generation in the mitochondria via oxidative phosphorylation. Delivery of oxygen, DO2, to tissues. Also known as oxygen flux, the amount of oxygen delivered to the tissues per unit time. It is determined by cardiac output and arterial oxygen content, CaO2. The formula is DO2 equals CO times CaO2 times 10 in mils per minute. The full formula is DO2 equals CO times 1.34 times Hb times SaO2 times 10, where DO2 is the delivery of oxygen in mils per minute, CO is cardiac output in liters per minute. This can be measured by using pulmonary artery catheters or other non-invasive methods. 1.34 is the oxygen binding capacity of hemoglobin in mils per gram. Hb is hemoglobin concentration in grams per deciliter. SaO2 is arterial oxygen saturation of hemoglobin, expressed as a ratio HbO2 to total Hb. It is measured using pulse oximeters. The multiplier of 10 converts the CaO2 from mils per dl to mils per liter. Oxygen content of blood is considered equivalent to the Hb bound fraction, as the contribution of dissolved oxygen in plasma is very small. Further discussion on arterial oxygen content CaO2 in mils per deciliter. 1.34 times Hb times SaO2 plus 0.003 times PaO2. Concentration of Hb bound oxygen. HbO2 equals 1.34 times Hb times SaO2 in mils per deciliter. When Hb is fully saturated with oxygen, SO2 equals 1. Each gram of Hb binds 1.34 mils of oxygen. 1.34 mils per gram is the oxygen carrying capacity of hemoglobin, also known as Hafner's constant. It is discovered by Karl von Hafner, a German physician, in 1894. It is the volume of oxygen in mils carried by 1 gram of hemoglobin. If measured in vitro, it is 1.39 mils per gram. If measured in vivo, it is 1.34 mils per gram. Figures vary due to the disagreement between different forms of hemoglobin measurement, changing methods of measuring hemoglobin's oxygen content, and the presence of abnormal forms of hemoglobin, such as carboxyhemoglobin and methemoglobin, that are less able to carry oxygen. Some researchers quote the oxygen carrying capacity of hemoglobin as 1.306 mils per gram. 1.39 was a theoretical figure based on a more exact determination of the molecular weight of hemoglobin using raw German stoichiometry. The figure of 1.306 mils per gram was derived from direct measurements of oxygen carrying capacity and hemoglobin concentration by I.C. Gregory using several ex vivo samples. Dissolved oxygen is 0.003 times PaO2 in mils per deciliter, where PaO2 is partial pressure of oxygen in arterial blood in millimeters mercury, and 0.003 is the solubility coefficient of oxygen in plasma in mils per deciliter per millimeters mercury at normal body temperature of 37 degrees Celsius. Dissolved oxygen can also be expressed as PaO2 times 0.0225 if PaO2 is measured in kPa. 0.0225 is mils of oxygen dissolved per 100 mils of plasma per kPa. The contribution of dissolved oxygen is very small under normal atmospheric pressure and body temperature and can be ignored, as oxygen has poor solubility in the plasma. At normal body temperature of 37 degrees Celsius, each 1 mm mercury increment in PO2 will increase the concentration of dissolved oxygen by 0.003 mils per dl or 0.03 mils per liter. Dissolved oxygen becomes significant under hyperbaric conditions. With the oxygen solubility coefficient of 0.003 mL per dl per mmHg at atmospheric pressure, breathing air, dissolved oxygen content is around 0.26 mL per dl. If breathing 100% oxygen, dissolved oxygen content is 1.7 mL per dl. With the oxygen solubility coefficient of 0.003 mL per dl per mmHg at 3 atm in a hyperbaric chamber, breathing 100% oxygen, dissolved oxygen content is 5.7 mL per dl. Dissolved oxygen thus can make a significant contribution to oxygen delivery to the tissues at this level. Oxygen cascade, also known as hierarchy of partial pressure gradients for oxygen. PO2 changes according to the location in the body and is represented by the oxygen cascade, which is a series of stepwise decreases of PO2 as oxygen moves from atmospheric air to mitochondria in the cells. Dry room air, it is influenced by barometric pressure and inspired oxygen concentration. Formula is PO2 equals FiO2 times PATM, and it is 21 kPa or 160 mmHg. Humidified air in the trachea. Humidification of dried inspired gases occurs. The formula is PO2 equals FiO2 times PATM minus PH2O and is normally 19.8 kPa or 150 mmHg. Next is alveolar gas. Gas exchange in alveoli occurs and it is influenced by alveolar ventilation and oxygen consumption. Formula is PaO2 equals FiO2 times PATM minus PH2O minus PaCO2 divided by R, and it is normally 14 kPa or 106 mmHg. Next is arterial blood. It is influenced by VQ mismatch and it is normally 13.3 kPa or 100 mmHg. AA gradient is usually less than 2 kPa. Venous admixture causes decrease in PO2 from the previous step. Next is end capillary blood. Diffusion of gases occurs at the tissues. Diffusion barrier is negligible for oxygen. It is influenced by blood flow and hemoglobin concentration. It is normally 6 to 7 kPa or 45 to 55 mmHg. At the mitochondria, it is normally 1 to 5 kPa or 7.5 to 40 mmHg, and on average it is 1.5 kPa or 11.25 mmHg. In the veins, normal PvO2 is 6.3 kPa or 47.25 mmHg. These values vary slightly according to different research. The pasture point is the oxygen concentration below which oxidative phosphorylation cannot occur in the mitochondria. It is considered to be 1 mmHg or 0.13 kPa. A reduction in PO2 at any stage causes PO2 reduction in subsequent steps. This risks inadequate mitochondrial PO2 for aerobic metabolism. Oxygen consumption. Oxygen is not stored in tissues, thus the rate of oxygen uptake into tissues equals oxygen consumption, VO2. Calculated VO2. VO2 equals CO times CaO2 minus CvO2 times 10 in mils per minute, where CO is cardiac output. CaO2 minus CvO2 is the difference between arterial and venous oxygen contents. The multiplier 10 is used to convert mils per dl to mils per liter. CaO2 and CvO2 share a common term of 1.34 times Hb, thus VO2 equals CO times 1.34 times Hb times SaO2 minus SvO2 times 10. The sum variability of the four measurements in the formula totals to plus minus 18%. This is because each of the measurements used to calculate VO2 has an inherent variability. Thus, a significant change in VO2 must be a change that is at least plus minus 18%. Calculated VO2 does not equal whole body VO2 because calculated VO2 does not include oxygen consumption of the lungs. VO2 of the lungs is normally less than 5% of whole body VO2. However, VO2 of the lung can be up to 20% of whole body VO2 during inflammatory processes of the lung. Measured VO2. An oxygen analyzer measures the fractional concentration of oxygen in inhaled and exhaled gases, and VO2 is derived as follows. VO2 equals VE times FiO2 minus FeO2, where FiO2 is fractional concentration of oxygen in inhaled gas, FeO2 is fractional concentration of oxygen in exhaled gas, VE is volume of gas exhaled each minute. Metabolic carts used by nutrition support services can measure whole body VO2 at the bedside. The inherent variability of measured VO2 is plus minus 5%. These are normal and abnormal values of systemic oxygen balance. Measure of blood oxygenation. For arterial blood, partial pressure of oxygen is 90 mmHg. For venous blood, it is 40 mmHg. Percentage of oxygenated hemoglobin. For arterial blood is 98%, venous blood is 73%. Hb-bound oxygen for arterial blood is 19.7 ml per dl. For venous blood is 14.7 ml per dl. For arterial blood, dissolved oxygen is 0.3 ml per dl. For venous blood is 0.1 ml per dl. For arterial blood, total oxygen content is 20 ml per dl. For venous blood is 14.8 ml per dl. Blood volume for arterial blood is 1.25 liters and for venous blood is 3.75 liters, assuming total blood volume of 5 liters. Total volume of oxygen in arterial blood is 250 ml and for venous blood is 555 ml. Measure of systemic oxygen balance. Normal DO2 is 900 to 1100 ml per minute or 520 to 600 ml per minute per meter square. In tissue hypoxia, DO2 is variable. The normal VO2 is 200 to 270 ml per minute or 110 to 160 ml per minute per meter square. For tissue hypoxia, VO2 is less than 200 ml per minute or less than 110 ml per minute per meter square. Normal O2 or oxygen extraction ratio is 20 to 30%. In tissue hypoxia, O2 is 50% or more. Normal SVO2 is 65 to 75%. In tissue hypoxia, SVO2 is 50% or less. Normal SCVO2 is 70 to 80%. SCVO2 is not determined in tissue hypoxia. Normal lactate is 1 to 2.2, which varies according to the different laboratories. In tissue hypoxia, lactate is more than 2 millimoles per liter. Oxygen extraction, O2 Definition. It is the fraction of delivered oxygen that is taken up by the tissues. O2 equals VO2 divided by DO2. O2 also equals SaO2 minus SVO2 divided by SaO2, as VO2 and DO2 share a common term of Q times 1.34 times Hb times 10, where SaO2 equals arterial oxygen saturation and SVO2 equals venous oxygen saturation. As SaO2 is usually kept close to 1, O2 equals SaO2 minus SVO2, thus equals 1 minus SVO2. The balance between DO2 and VO2 can be monitored using a single variable, SVO2. O2 is commonly expressed as a percentage after multiplying by 100. It represents the fraction of oxygen delivered to tissues that is used by aerobic metabolism. Normal O2 is 20 to 30%. In healthy adults at rest, only 20 to 30% of oxygen delivered to tissues is used by aerobic metabolism. This large spare capacity allows the body to cope with decreases in DO2 without compromising aerobic respiration during the initial phase of hypoxia. O2 varies depending on the type of organ. For example, the heart has an O2 of 60% and is especially sensitive to ischemia. Mixed venous oxygen saturation. It is obtained from venous oxygen saturation measurement of blood in pulmonary arteries. It represents global whole body measure of venous oxygen saturation, SVO2. It has to be obtained using a pulmonary artery catheter and it is not routinely available. SVO2 equals SaO2 minus VO2 divided by CO times 1.34 times Hb. If SaO2 equals 1, SVO2 equals 1 minus VO2 divided by DO2. SVO2 is normally 65 to 75%. Conditions where SVO2 decreases: if VO2 increases, such as during increased metabolic rate, or when DO2 decreases, such as in anemia and decreased cardiac output. Central venous oxygen saturation, SCVO2. It is the oxygen saturation of the blood obtained from the superior vena cava. It is a popular surrogate for SVO2 as it is more readily available. It is measured by blood samples from central venous catheters or continuously measured using fiber optic catheters. SCVO2 is higher than SVO2 by 5% in critically ill patients, and normal SCVO2 is 70 to 80%. Although large discrepancies between SCVO2 and SVO2 exist in hemodynamically unstable patients, changes in SCVO2 and changes in SVO2 correlate closely. Thus, trends in SCVO2 are more reliable than single measurements. Supply and demand. This curve demonstrates the relationship between DO2 and VO2. Control of VO2. Changes in DO2 are accompanied by reciprocal changes in oxygen extraction. VO2 equals DO2 times O2ER. The aerobic support system maintains a constant rate of VO2 despite variations in DO2, as oxygen extraction is adjustable up to the point where it is maximized. The inflection point on the graph is the critical DO2. The supply-independent phase lies above the critical DO2. An increase in O2ER compensates for a fall in DO2 and thus leads to no change in VO2. During the supply-dependent phase, it lies below the critical DO2 and O2ER is maximized, VO2 begins to fall. Switch from aerobic to anaerobic respiration occurs and lactic acid is produced. Critical DO2. Definitions. It is the degree of oxygen delivery below which supply is inadequate to meet oxygen demand. It is the point where O2ER is maximal and the anaerobic threshold is reached. It is the lowest DO2 that is capable of fully supporting aerobic metabolism. It is variously defined as 4 to 8 mL per kg per minute. It is not a fixed value as it is dependent on many other patient factors. Detecting tissue hypoxia. DO2. It is not possible to identify critical DO2 in any individual patient. VO2. It is decreased during hypometabolism and tissue hypoxia. Since hypometabolism is rare in the critically ill, a decrease in VO2 suggests tissue hypoxia. O2ER. When SaO2 minus SVO2 increases to around 50%, this represents the anaerobic threshold where maximal oxygen extraction occurs. When SaO2 minus SVO2 is more than or equal to 50%, this suggests tissue hypoxia. SVO2. When SVO2 decreases to around 50%, this represents the anaerobic threshold. When SVO2 is less than or equal to 50%, this suggests tissue hypoxia. SCVO2 of less than 70% is abnormal, and SCVO2 of more than 70% has been recommended as a goal of therapy to increase DO2. However, a SCVO2 value that identifies tissue hypoxia has not been identified. Blood lactate. Hyperlactatemia can occur under many conditions, for example, inflammation in sepsis, shock such as hypovolemic, cardiogenic or septic shock, drugs such as antiretroviral agents, beta-2 agonists, adrenaline, linezolid, metformin, nitroprusside, propofol and salicylates, toxins such as carbon monoxide, cyanide and propylene glycol, thiamine deficiency, and other causes such as severe alkalosis, fulminant hepatic failure, and seizures. The following discussion will be about hyperlactatemia from derangements in tissue oxygenation. Lactic acid is the end product of anaerobic glycolysis. Thus, hyperlactatemia is used as a marker for tissue hypoxia. Lactic acid measured in venous or arterial blood yields equivalent results. Individual laboratories report varying upper limit of normal serum lactate concentrations, which ranges from 1 to 2.2 millimoles per liter. 2 millimoles per liter is a common cutoff point. In-hospital mortality rates in percentage are lower in patients with lower initial serum lactate and high lactate clearance. The greatest increase in ICU mortality rates occur when serum lactate levels is 4 or more millimoles per liter. Mortality was lowest when normalization of serum lactate within 24 hours occurs. The mortality rate increases dramatically when serum lactate remains elevated after 48 hours. Rate of lactate clearance has greater prognostic value than the initial lactate level in patients with septic shock. Thus, monitor serial serum lactate levels in patients with hyperlactatemia. In cytopathic hypoxia, oxygen utilization in mitochondria is defective. It is the presumed mechanism for cellular dysfunction in septic shock. It differs from tissue hypoxia because in cytopathic hypoxia, tissue PO2 and SCVO2 may be normal or increased. Hyperlactatemia is due to inhibition of pyruvate dehydrogenase and may not be the result of inadequate oxygen supply. Optimization of oxygen flux. 4 variables that can be manipulated to optimize oxygen flux includes heart rate, stroke volume, Hb concentration, and oxygen saturation. Cardiac output. Measurement of cardiac output will be discussed in a future video. Cardiac output can be optimized by optimizing ventricular preload, by optimizing volumic status, treating arrhythmias, and augmenting cardiac contractility by using inotropes. Oxygen saturation can be optimized by enhancing cardiac performance, treating pulmonary conditions such as pneumonia, atelectasis, and bronchoconstriction, and providing supplementary oxygen. Hemoglobin concentration. Given a cardiac output of 5 liters per minute and an SpO2 of 100%, oxygen delivery at a hemoglobin concentration of 10 grams per deciliter is 670 mL per minute. At 15 grams per deciliter, it is 1005 mL per minute. Tissues cannot utilize all oxygen bound to hemoglobin. The last 20 to 25% of oxygen remains bound to hemoglobin and cannot be utilized by tissues. If the oxygen carrying capacity of blood is reduced, such as during anemia, cardiac output must increase at rest to maintain oxygen delivery. Myocardial depression during anesthesia in this situation may result in tissue hypoxia from inadequate compensation. The role of dissolved oxygen under hyperbaric conditions has been discussed in the previous section. These are my references. Thank you.